we had one patient in our ward. He was 65-year-old male. He had Parkinsonism for 5 years. He was under levodopa, carbidopa, amantadine, and he was taking these medications for long time. But this time he was admitted in our ward for hallucinations. He was having auditory and visual hallucinations, delusions. So he was exhibiting psychotic symptoms for a few weeks. So we had admitted him for evaluation. So how to evaluate in this case? So if any patients under anti-parkinsonian medications presents with psychosis, then should we discontinue all anti-parkinsonian medications? Because he had good improvement in his symptoms after starting anti-parkinsonian medications. So if you suddenly discontinue anti-parkinsonian medications, then all those symptoms might return, and you cannot discontinue levodopa, carbidopa suddenly, because if you remove suddenly, then patient can develop features like neuroleft malignant syndrome, like hyperthermia, rigidity. So we do not directly discontinue any anti-Parkinsonian medications, rather we reduce the dose, we titrate the dose down. So let's talk about our case. So in this case, first of all, we ruled out if there were an infection that is causing delirium, because these psychotic symptoms can be part of delirium sometimes. So we ruled out urinary tract infections, pneumonia. There were no skin infections. He did not also have fever. So those were ruled out. Then second part or second step should be to rule out whether patient is taking any anxiolytic medications or any sedatives, like for sleep. Patient may be taking medications like zolpidem, benzodiazepines. So those should be ruled out. Our patient was not taking those medications. Then third step is we have to discontinue anti-Parkinsonian medication which is least potent. First of all, least potent. Our patient was under amantadine and levodopa, carbidopa. So we did not discontinue levodopa, carbidopa, we discontinued amantadine. But even after a few days, he was still having those symptoms. There was no improvement. Then we discontinued levodopa, carbidopa as well. We did not discontinue it all at once, but we gradually reduced the dose and we discontinued it. Despite his symptoms did not improve, then we added quetiapine, right? And after that, his symptoms improved. So we had to add D2 blockers. Quetiapine has minimal D2 antagonism. If you compare to risperidone, it is more potent. Risperidone is more potent D2 blocker, but quetiapine is less potent. So in such type of patient who is also having Parkinsonism, we prefer less potent D2 blocker, because if you use most potent D2 blocker, that can aggravate his Parkinsonian symptoms, and his symptoms improved, and then we were able to discharge him. So I told you about, first of all, you have to discontinue whether if he is taking any anxiolytic, sedative medications. If not, then we have to discontinue anti-Parkinsonian medications. But first of all, discontinue least potent, like discontinue amantadine. Then if patient is taking dopamine agonist like bromocriptine, cabergoline, then discontinue those. Then MAOI inhibitors, then COMT inhibitors, and in the last you can discontinue levodopa, carbidopa, right? And despite a patient's symptoms does not improve, then we can add minimally potent D2 blocker. Like in our case we added quetiapine, but you can add clozapine, pimavanserin. But as I told you, risperidone is a highly potent D2 blocker, so do not add risperidone.